Hi, good afternoon, everyone. I just wanted to welcome everyone to our summer webinar series. I'm Leilani Doyle, Director of Education and Awareness for Senior Site Care, and I'm so glad to have everyone here on the Roadmap to Recovery webinar. This is such an impactful time, hopeful time. We see so much change going on and taking away some of the restrictions we had in the past. We also have reflected back on the changes we've seen in the industry collectively. As a company, we service a good number of nursing homes and long-term care facilities in the Texas area. And we see some patterns emerging. We believe that as we go into this recovery phase, getting back to normal and getting things going, we know it's not going to be the same. It's going to be different. It's going to be better. And we want to help you with some guidelines and some ideas and some benchmarking you can use to make things better or think about things differently. So I hope you enjoy the webinar. It's all about the post-COVID strategies for nursing home facilities, and it is part of our core values to continue to present this information going forward. So joining me is Dr. Elizabeth Klepper, who is our regional director for North Texas. She has a wealth of experience in working with senior site care and serving the nursing home facilities and long-term care facilities in both the rural and urban areas in the Dallas and North Texas region. And also Tom Forsberg, who is our regional director of our South Texas region, which covers from Corpus Christi to San Antonio, Austin, Del Rio, all kinds of interesting places. And Tom comes to us by way of being a former administrator at a long-term care facility, a very specialized long-term care facility, and still maintains those administrator credentials to this day. So I don't know, Dr. Klepper, if you'd like to say a few words, just so we know your voice when you talk, for those that are just listening in.
Hi, I'm Dr. Klepper. Thank you guys for attending the webinar. We're very excited to present the roadway to recovery.
And Tom?
Good afternoon, everybody. Yes, Tom Forsberg, and I'm also very excited to be here today, and thank each one of you for participating and watching.
So during the call, during our webinar, we may also be joined by Dr. Ahmad, who services some of our urban areas in the Dallas region. She's out on call seeing patients. That, of course, certainly comes first. But when we go through some of our care models or how they're expanded, we thought it'd be very interesting for our audience to hear directly from a practitioner who has day-to-day experience in some of these changes there. So let me paint the picture for you. During the crisis, we know nursing homes were the center of a lot of attention. And as a result, we got some well-needed funding through the Provider Relief Fund and PPP loans, which was critical and crucial for maintaining this current needed service for so many. And in addition, it was supplemental. It helped provide staffing. It helped provide the PPP equipment, all of that. However, as a result of the focus on nursing home facilities, AHCA reports that 55% of nursing homes are still operating at a loss based on a 2020 survey, which means despite this funding, the demands and the pressures and the burden placed on nursing homes during this crisis is still very much being impacted, while some of the federal money is drying up and nursing homes are left to their own means and their own initiatives for building their census, for specializing and doing all those things that businesses have to do to continue to serve those patients and residents in need. In addition, we see occupancy is down as a direct result of families being uncertain, and we want to make sure that we can give you the tools to help build that confidence in families. And ultimately, the very specialized skilled nursing facilities in Texas report only a 55.9% occupancy. So we know that the nursing home industry has been impacted, but things are looking up. And let us go through and see how we can share some of the ways we're observing within Texas and other areas that might be helpful for your community. This is something that's very key to Senior Site Care's core values. We are very much a values-based organization. We were driven to deliver compassionate care to our patients, even during the crisis. We created all kinds of extreme measures, including our SAM, which is still in use for portable telemedicine for those who have assistive problems. And we've done all kinds of integrations to nursing home facilities through our Teams environment to drive this awareness. So know that when you're working with senior site care and listening to the information we're sharing is being shared to you from a sense of our deep core value driven for listen, learn, and share all the information we gather every day so that we can all continue to grow and benefit and the industry can continue to serve the population that is so in need. So if you think about moving forward, so we know where we've been, we don't want to go back there. But moving forward, some of the trends that we're seeing coming into the market more and more evident is differentiation through specialization. We've observed, and the nursing home facilities have observed, the need for specialty units is critical, especially during COVID. When you have limited access to the types of specialists, when your population is quickly changing and you don't have the skills nursing staff to deal with it, it is a key factor in building your census is how you can change your differentiation with very specialized services supported by the physicians and the experts that you need. Specialized approach can also help you assure families and residents that where their loved one is going has access to the care professionals that can deliver the highest quality of life, which will help rebuild the trust and increase your census and support from families who are looking to place their loved one in a facility that's matched to their special needs. In addition, throughout the crisis and today, training and education has been impactful. We saw that we had a lot of need and requests for staff training. Dr. Klepper, I know that during the crisis, you performed numerous in-service messages to help give staff information on reducing stress, de-escalating situations, and identifying the need for care. Because when your staff can't recognize what the behaviors may be indicating, the proper care can't be provided or may not be provided, it may go unnoticed or thought of differently. I don't know if you'd like to add some commentary to that, Dr. Klepper.
I would like to say that we're definitely noticing a change in the nursing home populations. So you talked about the census. During COVID, we noticed a decrease in the nursing home census. And consequently, many of them have admitted patients that they normally wouldn't. So patients with like higher acuities, comorbidities, just more complex cases. So they're coming to us and asking us for more specialized training. And as you said, de-escalation it's come up quite a bit. So they're working very hard to recognize that a certain mix of patients may not be the most safe environment. Part of that will be expressed through our training.
Yes, I agree. I think we'll cover that deeper in the session. And then in addition, we're investing in technology. Clearly, technology was a savior for us in the past, and it is going to be the way moving forward. Senior Site Care continues to expand our technology, and some of that is based on demand from facilities and demand from corporations that are looking for collaboration through our virtual health network, which syncs up through a HIPAA certified facility using Microsoft Teams. So you have a safe way of engaging and interacting on a real-time basis to share documentation and all the support information. So we know technology was there in the past for primarily telemedicine, but the funds that were invested during the crisis are going to pay off in terms of delivering a greater return on investment through ease of collaboration, hallmark of senior site care. The most telling evidence is that the demand for psychiatric and psychological services increased dramatically. And this statistic was pulled back in May. Our June numbers look even more telling in terms of the pent-up demand for services. Clearly, it's not a facility that has not been impacted by underservice during this, especially in the therapy areas where you typically have longer visits and it's more difficult to get providers in for a longer visit during the pandemic. So we are here supporting that. We've recognized it. We've got the tools and initiatives to do that. So know that this is something that is helpful to your organization, helpful for rebuilding your environment, and rebuilding trust with the families that you serve. We've talked about how they're critical. We've seen the demand. We are a values-based organization. We have a deep talent pool directed by MDs and collaboration with psych certified mid-levels. And, Tom, I don't know if you want to say a little bit about our deep talent pool and how that's useful for finding the right physician for the right location. So I know you've been very successful in your region at obtaining that.
We're very fortunate that we have MDs in each market. Our MDs do collaboration with our mid-levels monthly. So they talk about treatment plans, they talk about dose reductions, they talk about the items that need to be talked about, not only for regulatory, but for the overall wellness of the patient.
Which is so crucial, and they're geographically located. So I think that's an impactful statement. If you think about customized facility programs, and Tom, I know you are familiar with working with specialized units and having to deal with different specialties. I know there are all kinds of specialties emerging. So I thought you might share a bit of information about the specialties that you're seeing and the rationale behind that.
Well, I will say that when I was a regional up in the Panhandle, that the service that I was using, I was first introduced to senior psych care probably maybe 5 years ago. My current provider at the time was for psychiatry. They would come in once a month, and they did a wonderful job when they came in. But the problem that I had was we specialized in behavioral type people. Our buildings were known as the last house on the left, which we took clients that was pretty much in every other nursing home, and no one else wanted them because of their behavior. So we would take them. We felt every human being needs the dignity of having meals and being treated like human beings. So we would admit them. The problem is I was discharging an awful lot of residents to the psych hospital. When I onboarded senior psych care, we went from one visit a month from my previous provider to one visit a week from senior psych care. Now, what this did was we caught the behaviors in the early stages, and we were able to treat those behaviors in-house. And it didn't dawn on me until about the second or third month after senior psych care was in my building that I went from averaging one discharge a week to one discharge a month. Now, we still discharged to the psych hospital, but we had reduced our discharges because of the frequency of visits that senior psych care had promoted. So it was a wonderful program. Now as a regional for senior psych care, it's interesting because we have wonderful programs that we offer to the nursing homes. For example, dose reduction rounds, which we call behavior rounds. We call them behavior rounds because they are resident specific and the meetings are resident driven. If we call them dose reduction rounds, that kind of gives a connotation to where it's a facility driven meeting that we're going to just reduce medicines because that's what the law dictates. So we call them behavior rounds. And when we go through our behavior rounds, we do experience some dose reductions. And we also, during the behavior rounds, there may be some doses increases, just depending on the team. When I say the team, it's going to be the facility director of nurses, the assistant director of nurses, the MDS nurse, social worker, and sometimes the activity director, and sometimes the administrators participate in behavior rounds. So we'll go through the regimen of everybody that's on our caseload, and we offer this service. Senior Psych Care offers the service. Some buildings do them monthly, some buildings do them quarterly, and some buildings choose not to do them at all. Now, the buildings that choose not to do them at all, their verbiage that I hear is, your provider does dose reductions on a weekly basis if there's a dose that can be reduced, or at least monthly with the pharmaceutical recommendations. These pharmacy recommendations are addressed. So the buildings that don't choose to participate in behavior rounds, they tell me that those meetings aren't needed because y'all are already doing your job. That's always good to hear, but we do offer that service to the nursing homes.
That is wonderful to give us that insight, but I've heard recent emerging changes about some facilities moving towards more specialized units, including specialized wings or dedicated facilities for specialized needs, psychiatric or gender-based separation. Have you seen that in your market?
I have, and this is, it's not a new concept, but it's one that's being capitalized on, I should say. And I'll just say for a secured unit, like a male secured unit. And so we work with the nursing homes to have a quality program for those specialized units if we're called and asked to help.
Right.
But that is also another service that we provide.
And then in terms of geographically located psychiatrists and psychologists, maybe Dr. Klepper, you could give us a little bit of hint, because I know you've got the real challenge of serving both urban and a very compact urban area, and then a very rural area in your region. So staffing must be, of course, an utmost concern for you, and limiting the miles driven, and then also the segregation or the appropriate approach between psychiatrists and psychologists. So maybe you could talk a little bit about how you measure and assign the geographic locations to your physicians and mid-levels?
So yeah, geography is definitely very important. We really try to keep the providers as close to their physical residences as possible. The first reason is because we want them to be accessible for the nursing home staff and the patients. And the other part of that is we don't want them to burn out. In cases where it's not possible for them to get there as quickly as they need to be, we have used telemed, especially during COVID. It's been very helpful. But we try to have them in the homes weekly, and the psychiatrist and the psychologist initiate the course of treatment, and then the mid-levels and psychotherapists assume the course of treatment.
So maybe you could give, for the audience, sometimes I get the question asked, what's the difference they've got between psychiatrists and psychologists, and why does this combination make a unique value to our facilities? Because oftentimes it's not clearly understood, even by seasoned veterans.
So the psychiatrist and the psych team provide the psychotropic medications, and SBC's model was built on the psychiatrist, initiating that course of treatment and collaborating with the mid-levels, the nurse practitioners and PAs, and making sure that their treatment plan is reviewed at least every 30, 60 to 90 days. But typically it's reviewed each session, and they collaborate with the psychology team or the therapy team. The psychologists do, intakes just the same, but they don't prescribe the psychotropic medications. They go into the homes and they perform individual, family, or group psychotherapy. What we found, you talked about being a very value-based, data-driven society now. So what we found is we've really had significant decreases in hospitalizations, much like Tom said, and we've been very successful at the gradual dosage reduction because the teams are so collaborative and because it's such an integrated treatment approach.
Thank you for that clarification. No discussion would be complete without documentation and compliance support. We know it's mandatory. We know getting notes in on time and sharing that with all the team members, because collaboration extends far beyond just collaboration within our team. It extends to all the participants in the treatment, including the facilities, the PCPs, the pharmacists, physical therapists. Everyone is involved. So having that documentation and compliance ready and intact for when surveys come in, somebody comes in to do a survey, you've got everything to support it, and you've got the information that's been documented through our behavioral rounds, which helps you track successes and the evidence needed. The one thing that kept coming up over and over again over the course of the last 4 months is the need for training and education by the staff. So I don't know which one would like to, if you, Dr. Klepper or Tom, you'd like to tackle that, but I know that's something I've heard from our practitioners and our facilities alike. They're all hungry to have their staff trained to properly deal with behaviors they can't understand.
Well, personally, I was asked to talk about and we do have some in-services, some training for the staff for aggressive behaviors and how to address aggressive behaviors. Unfortunately, by the time I'm asked to do the in-service, it's pretty much a regulatory issue. The nursing home maybe got a deficiency for maybe a resident-to-resident altercation, but we do have training modules that we can introduce to the facility staff if asked.
I think those all can be tailored based on the request. That's the nature of our collaboration with the facility.
Yes.
Offer these modules, make them available. I know we also have some compliance training and some documentation training that's available through our compliance area as well. And Dr. Klepper, I know you've done some in-services from a therapy side to help reduce staff stress. So we've talked a lot about the facility and how we interact with the facility, but we're really very patient focused. And in terms of patient focus, it's all about delivering that continuity of care protocol. I'm not sure if Dr. Maud was able to join.
Yeah, hi, I'm Dr. Ahmad.
Great, wonderful. Thank you and welcome. I'm so
Sure,
sorry
no problem.
see you on the call, but welcome to our webinar. And we're so delighted to have you part of this. I know you've not
Thank
worked
you.
a webinar before, but you're in the field every day. So I thought who better to cover our continuity of care protocol in action and how this has really been the hallmark of senior psych care. So in terms of talking about the various steps, one of the things that I hear often is that it's all about evaluation. And we know that when patients come in, there's an adjustment period. And based on how that adjustment period goes, it might be referred to senior psych care, to their partner in psychological care by the PCP. Dr. Med, do you want to comment a little bit about the adjustment period and how you deal with evaluations and diagnosis?
Sure. Really, the ideal thing is that any patient that's coming in on a psychotropic should be under the care, of a psychiatrist and possibly a counselor, if need be. So we ask that the homes go through their patients, and if anyone is on a psychotropic or they feel like they're having some sort of, social problem, mental problem, for them to refer to us. And, PCPs, especially in this setting, do not feel particularly comfortable handling their psychotropics. It's very beneficial to the patient that then we're on the team. I try to collaborate with the PCP and see if there's any specific concerns. So we try to, give it like a holistic approach where it's not just the counselor or the psychiatrist just doing the psychiatric part, but really more kind of having a team approach where we are working with the PCP or with the PA and trying to, get the patient the best result. And our aim, of course, is always to have the patient on the lowest dose and the least amount of medications if we feel that they have to be on them.
Sure. So once you get the referral, then you generally come into the facility and do the diagnosis, which might include a little bit longer visit than our general regular psychiatric visit.
Yeah, sure. I mean, once we get the referral, I typically start out by doing a very detailed interview of the patient. And oftentimes that will entail calling a family member, talking to somebody from the staff, because a lot of the patients are not able to speak coherently or to give me their complete history. And that also is beneficial because the family feels involved. They're able to give us a whole new side of the picture, which the patient may not be able to tell us. So really everything from a psychiatric standpoint really hinges on that first assessment, which is just a very detailed history. Because from that, we glean the symptoms, how long they've been having problems, what treatments have worked in the past, what haven't. Really for psychiatrists, or the PAs that we work with, the NPs, we have to depend on that first interview. And then we go to the chart, we can see the lab, we can see if any tests or imaging studies have been done, which can help us, CT scans, MRIs, but really it's the history, I would say. That's the most important thing.
And from that, you develop a master treatment plan that uses a guide for the program, for the treatment program.
Right. We construct a plan which we communicate to the staff and we document it. I will also make it a point to let the NP or the PA know that I'm sharing the home with, that this is what the plan is. And because we talk often, we communicate, we talk about it to patients, then that is what gets followed. If there's any problem with that plan, then of course we will change it and we will tailor it to, whatever the problems may be that the patient may be having. But yeah, everything is kind of focusing around that treatment plan.
That's really the difference. It's not just a one and done. That's why when we were working through how to really put our continuity of care protocol into some visual, the evaluation part is ongoing. You're always evaluating, you're always thinking, because unlike coming in to do triage, treat, fix it, and go away, we're very much about this constant review which really creates a better outcome for the patients and likely better environment for the facility as a whole.
Right. Right. And I mean, with us, what's really, I think, beneficial for the patient, like a particular asset, is that there's not just one pair of eyes on the patient. It's not just me, not just the MD. It's not just the mid-level. It's us together. If the patient is also getting psychotherapy services, it's the psychologist, it's the social worker. So that may be like 2, 3, 4 people all working together on one patient. And that's a really big talent pool right there. So everybody kind of brings in their forte, to get the patient the best care.
Yeah, that's wonderful. I'm going to imagine that families would take a lot of confidence in that, and facilities that have that at their disposal and can talk to their families, their prospective residents about this care protocol would garner a lot of trust and respect and comfort.
Right, definitely. And I mean, we're there to speak to the families. We are people ourselves. We know if our loved one is in the hospital, nursing home, sometimes you just need to speak to the provider. So we make ourselves available to the families. They just need to communicate to the staff that they would like to speak to us, and we will carve out the time and we will, speak to them. Sometimes they just need that assurance, not enough to hear it from a second party, from the staff. They want to actually know what the doctor's thinking, what the provider's thinking. So that kind of makes them feel at ease.
Yeah, I can only imagine. I know from direct experience with my own mother-in-law having that interaction, how comforting it is and how many questions we all have and had as the disease progressed. So wonderful. And it's not a one and done. I know you talked about the longer visit at the beginning, the initial evaluation. But I know periodically, and I know we talked about every 6 months, but it might be 6 to 12 months based on the flow of the patient through the treatment plan and how it's doing. You have another detailed assessment, which is something that Medicare puts forward as their guidelines for a standard of care.
So, I mean, every 6 months, I'm able to kind of have a more detailed assessment with the patient, and kind of between those 6-month visits, then it's more like follow up on my part, just to make sure that we're on the treatment plan, things are going how we want them to go. But then I also have that ability every 6 months to kind of go a little bit more deeper and evaluate the patient more thoroughly to kind of fulfill all the check marks.
All of our seniors deserve that level of care and consideration, what they've invested.
Absolutely.
I know from time to time there are advanced testing that might be recommended if changes happen that are unexpected or in all kinds of fashions. And we do provide advanced testing. It might be recommended based on changes in patient behavior, like be physical or mood behavior, a different cognitive impairment. And Dr. Mott, I don't know if you do the testing or if Dr. Klepper, if that's something more in your wheelhouse to discuss.
As an MD, we don't do really much of the testing. The home will request neuropsych testing, especially because a lot of our patients have cognitive impairment, which steadily gets worse over time. The MDs, are not really trained to do that, but the psychologist, that is their expertise. So they will come in with a battery of tests, and then that is how they conduct that.
Well, that must be a great benefit, having us work together to, when we identify it, we can actually do something to try and figure out what's going on.
Oh, right. Definitely. Like I said, it really helps that we're all kind of working together as a team.
Right. And I just wanted to add that in the event that, we do suspect a cognitive disorder or dysfunction, they do make referrals. The nursing home PCP can make referrals for a psychologist to come in and do, just like Dr. Ahmad said, extensive testing. What we find with the neuro testing, the neuropsychological testing, is that we can find exactly where in the brain the deficit occurs. And because we know what the deficit is, we can develop compensatory techniques for the patient to use. So for example, I had a patient in a nursing home one time and she had vascular dementia. Patients with vascular dementia sort of come in and out of recall, of memory, of their ability to really be with it in the moment. And many times they're aware of that. One of her compensatory strategies was she had a calendar. And she had it right next to her bed. And every time I came in, she asked me what my name was, what my credentials were, and why was I there. So she was really able to lead a much higher quality of life through that approach. You can really do some great things with these testing assessments.
And those testings are all things that we cover and are covered under the various agencies or payers. So in terms of thinking about the benefits to your facilities, we've talked about this collaborative care model, spelled it out. It has been what the senior site care was founded on. What we see is that this benefits your facility directly by increasing the census. So if you can align with a Jerry site specialty firm like senior site care, that has an advantage over other facilities who are having a hit or miss, non-collaborative approach from their psychiatric practice or relying on the PCP to do this heavy lifting in many cases, which happens. We see that happens often in the more rural areas. And families can take comfort in this, and that we're there for the entire resident life cycle. So it's not just the initial intake. We're always evaluating, we're always there. We are beyond triage. In addition, everyone likes to work in an improved environment. And there's nothing worse than having an environment that's having some issues. It comes from the staff. We know the staff went through a lot of stress over the last year. New folks coming in, they need to learn. There's some key de-escalation techniques that we can provide, some tips for staff to recognize behavior which you might not recognize as being a psychiatric or psychological issue. Also, the discipline we have to help you achieve the gradual dose reduction or your medication management that might be reviewed during your regular surveys and studies. And I know, Tom, you've talked a little bit about reduced psychiatric hospitalizations at the beginning, and that it's gone for the need for discharges to a psych hospital really has been proven to decrease by up to 75%, which has got to create a much more stable community. But anything else you'd like to say about the environmental approach? Because I know being an administrator, having an environment where everyone can function together crucial. But you might want to have some words there.
You know what I had learned was in the dining, and I'll just take for example the dining room experience at lunchtime. You know, when you get the 2 or 3 high stressors in the dining room, if you can get their behaviors under control, it helps the entire dining room with a much more pleasant dining experience. You know, we don't have to treat everybody and get everybody's behaviors totally under control. If we can get the high stressors under control, then we can get the rest of the room under control. I would also like to say that when we would get referrals on the fax machine or get them emailed to us, and my team, when I was administrator or regional, when my team would look at those referrals and say yay or nay. For the ones that were nay because of psychiatric issues, I would run those referrals under senior psych care under our provider that was coming to our building to see if they would take the challenge on looking at taking that resident under their caseload at the building. And I would say about 50% of them that we would normally decline, we actually took because of our partnership with senior psych care. So we actually did increase it helped with our census. You know, was that the saving grace? No, it wasn't the saving grace, but you know, it's not one big bang that everybody's looking for. It's the 10 little bangs that everybody's looking for to make a successful day. And that was one of the 10 bangs that helped me increase my census, was including senior psych care on the referrals that I normally probably wouldn't have taken. So anyway, I just wanted to add that.
Thank you. I think that's very impactful, especially with Dr. Klepper's observation that because of the dynamic we found ourselves in, a lot of facilities have taken patients that they normally would not have taken because they had to. And so having that access to care, having access to that specialization might be crucial to help maintaining a more stable and peaceful environment for the staff, for the residents, and for the families. We've talked about access to specialists, talked about the geography, the med management, the behavioral management. All of those things are something that are a hallmark. Access to specialists, we've touched on the virtual health network. It's something we'll cover more later in the year as we build it out. But during the crisis, we did rely heavily on technology. We do integrate now with a number of corporations for sharing information back and forth through a secure channel, which is HIPAA compliant, allows access to records on a 7/24 basis, allows you to get an easy chat off or collaborate in ways that are are much more difficult if you're relying on phone calls and person-to-person visits. Not that person-to-person visits are bad, it's just another way to augment. And then, of course, the behavior management, psychiatrists having the right med management in place, critical. Having therapy combined with that is really proven to yield beneficial results, both in achieving your med management goals as well as the overall patient quality of life. So having that coordination, I can't emphasize enough. I hope we've pointed that out throughout our presentation, but we'd love to engage more so that you can understand it deeper, because it is something that is a fairly new concept in the market and something that is worth looking at where you're looking to increase your census. I think it's working. I saw this statistic I wanted to share out there, kind of a way of closing a bit of good news. If you think back 10 years ago, Senior Site Care, fairly new company, still growing, grown significantly since then. Texas is ranked 51st in the number of facilities providing antipsychotic, and now they're ranked 11th. This came to us from one of our friends at the state, and I thought that was a very telling statistic. Not that we can take full credit for that, but I think clearly our influence in the market is something that we can hold evidence of making such a huge leap in this move forward. On the map to the left, it shows the locations where we're servicing. So we've got our reach. We talked about geographic regions and areas, so it gives you a little bit of focus about where we're located and servicing. And the continuity of care protocol, of course, is critical to that. We've seen great success in achieving that reduce in antipsychotic drugs. Just wanted to leave you with a bit of good news from the state that we're all doing a great job despite a very, very difficult environment. And I want to thank everybody that's been on the call listening for your help and your very needed work in this area. Our mission is to create a better quality of life for seniors, staff, and their families. I hope that came through in our educational materials today. It is something that we focus on, and it is our underlying decision-making factor when we take it on any daily task or big decision. It is crucial for us to continue to adhere and stay true to our mission and our core values, which talk about the compassionate care we deliver, how we cultivate excellence, which means we're always looking to do better. We hope to hear from you. If you are on this webinar and have ideas for future topics, please send them over. We get a lot of our ideas directly from the field or from questions that are asked. So we look forward to hearing back from you. We invest in technology and we analyze the data and information. So some of the ways we're able to staff geographically and get the right people in the right places is by looking at the analytics. We have access to so much. We can pull it, we can spot trends, we can share information across all of our regions, and that helps provide ultimate care. And we also inspire leadership. Leaders come to webinars, they get outside their comfort zone, they talk about things that they do day to day, and they make them interesting, because it is interesting if you don't do them every day. And I'm sure, Dr. Mott, you find it interesting. I want to thank you for being our special guest. And I hope next time you'll be able to be on camera, because I'd love to see you in person. But I really appreciate your thoughts and your very thorough description of your day-to-day work. So thank you. If you have any questions, we're here to help. You can contact our hotline. We've got a phone number there. You can always send email to any one of us, which you may know if Dr. Klepper or Tom is your regional director, or your regional director, Stacy in the Houston region, or you can send an email to SPC Cares. We're always here to listen, to learn, and to evolve. Thank you so much for participating in our webinar. We will be having another webinar in the late August timeframe, and then we'll also be at the THCA conference, where we're leading 2 sessions. The THCA conference is being held in Austin this year in the end of September, and it is a very focused healthcare conference dealing with long-term care facilities. I will sign off for now. Thank you for participating, and feel free to share this webinar information with your colleagues, because we're here to share. Thank you, everyone. Have a good afternoon.